All right, Zach, thanks again for presenting for us today. Take us away with the case.
Yeah, no problem. So the first aliquot's just going to be the chief complaint. So we have a 66-year-old female who presents with 10 days of a progressively worsening painful rash.
Oof, all right. I will say it is always a challenge to start off with a rash in a case because it's such a sensory dominant disease to think about. But even with some features of this case, we could start to make some progress. I think the features that are jumping out to me right now is that it's painful. And my assumption, although Zach, correct me if I'm wrong, my assumption is if it's progressive, it is relatively diffuse at this point in time too. Is that a fair characterization? Great. So the fact that we have a painful rash and a diffuse rash does a couple things for me. I really do always appreciate the framework of, is it an inside job or an outside job? And an outside job means that the rash is from some sort of exposure in the environment. And outside job rashes tend to be fairly localized to the area of exposure. I have a type 4 hypersensitivity rash to nickel. And so if I wear nickel jewelry or have a belt buckle that touches my skin for too long, I may wind up with a focal rash from that outside exposure. Whereas a diffuse rash is much more likely to be a systemic illness. Because it's a systemic illness, we think of it as an inside job that's leading to a rash moving from inside a process inside the body, moving to the surface of the skin. So, for example, a vasculitis may present with a diffuse purpuric rash. We may see some other disseminated infections like disseminated zoster that can do this. And then certainly systemic allergic reactions like anaphylaxis or other IgE mediated or mast cell mediated processes can present diffusely like this. So the fact that it's diffuse tells us that the likelihood of an inside job is high. And then the painful nature of the rash doesn't do much for me beyond something very important, which is that it makes us worried about the sinister causes of the rash. Almost all of the dermatologic emergencies, things like SJS or TEN, DRESS or drug-induced hypersensitivity syndrome, DIHS, and other sinister desquamating rashes tend to be painful in nature. So things that I'm going to be looking for, in addition to the fact that it's painful, looking for the presence or absence of fevers, looking for the presence or absence of mucosal involvement, and then certainly Zach will help us make progress on what the characteristic features of the rash are. But I think at this point in time, right, not all rashes are created equal, and this is a rash that really deserves our attention. We're getting clues for it being a systemic illness and potentially a sinister systemic illness that's leading to a painful rash. And I think beyond that, I'm really curious to hear more from you about how the rest of the case unfolds.
Yeah, for sure. All right, so I'm going to take you guys through the rest of the HPI here. So this patient's symptoms started 10 days ago, and the first symptoms she noticed were kind of generalized malaise, polyarthralgias involving her hips, knees, and hands, as well as myalgias and a fever of up to 102 at home. That was kind of followed by the appearance of these painful, pruritic, dark red patches that initially formed on her hands and nose. Um, Over the course of the next week or so, the rash became more painful and spread to involve bilateral arms, legs, chest, abdomen, and she had some associated neuropathic symptoms, mainly in the form of burning and numbness in her bilateral forearms and third through fifth digits. She actually went to a neighboring ER for these symptoms and was discharged with prednisone, cefuroxime, and an outpatient dermatology referral. However, the rash continued to progress, mainly in terms of pain, and her affected digits in her hands became more painful, swollen, darker, and developed some blistering, which is why she came to our hospital's emergency room. And so I'll pause there and let you guys go through that.
Awesome. I see that Sharmin has joined us. Sharmin, feel free to jump in wherever you want here. And if you want some time to get settled, I am also happy to take a stab.
Hey all. And it's so good to be here. I was so excited for VMR. My computer was so excited that it just crashed. So sorry for the delay. Yeah, I was able to catch the last part of your discussion, Jack, and as always, brilliant. So, and yeah, as you were mentioning, and I think like for me as an internist, rashes tends to be daunting, and I get very nervous every time I see a rash. And I think a approach that has helped me is that maybe my job is not to look at a rash and know exactly what it is, but to think about like what systematically is going on with the patient, what other organs involved, and how much progress I can make, and then also ask our dermatologist for help. And so in this case, I think what is really standing out to me is the degree of systems that potentially are involved, right? First and foremost, the patient is febrile. So thinking about an inflammatory syndrome that is accompanying this rash. And maybe I'll just walk through like how I think about like fever and rash, and then I'll pass it along to Jack to make some more progress. Possible. So I think when I think about like somebody coming in with a fever and rash, and here it's most likely acute to subacute nature of it. Oftentimes it kind of thinks about like your inflammation plus what could cause rash. So again, like I think most oftentimes our bucket always starts with infections, and oftentimes like viral syndromes are notorious. Most of them, except like VZV, are not the one that disseminated zoster doesn't really is as painful. So, we think about like ABV, CMV, HIV, all of those tend to rashes, and based on my experience, are not painful rashes. However, this patient doesn't seem to have a travel history, something worth noting, like if you had any exposure to like dengue, Zika, and then bacterial ones. I think oftentimes when we invoke bacterial, the couple of things we worry about with rash is neck rash. Again, this is so extensive that is probably not that, or something like toxic shock syndrome that is like worthy of mention here. And then in terms of like the drugs, and for me as an internist, I think like that is the one that I see the most is like the drug reactions. So thinking about this SGS, particularly those two with like sloughing off, oftentimes tends to be the one that it causes a lot of pain. And then like I think autoimmune diseases are worthy given like the amount of joint pain this patient is experiencing and other features of it, vasculitides, as you mentioned, Jack, with like thinking if this is like could be a palpable purpura, like stills, lupus can do anything. And I feel like IBD with extra intestinal features of it oftentimes can cause rashes too. Malignancy tends to be the diagnosis of exclusion for me in these cases. And oftentimes like lymphoma and leukemias are the ones that are left. And again, like painful, they oftentimes are not that painful. Anything else from your perspective, Jack?
No, I think you covered it.
All right, awesome. So with this next aliquot, I'm gonna go through some of the past medical history and then physical exam. So in terms of past medical history, she has a history of hypertension, hyperlipidemia, some seasonal allergies and asthma, and had a bilateral hip arthroplasty several years ago. And medications are losartan, rosuvastatin, Singulair, cetirizine, and that is it. For her social history, she has a doctoral degree and works as a counselor. There's no tobacco, alcohol, or recreational drug use. She's originally from South Africa, but has lived in the US for over 30 years and hasn't really had any recent significant domestic or international travel. And family history-wise, her maternal grandparents have rheumatoid arthritis, and her mom has coronary disease and had a bypass surgery around the age of 50. And I'll go ahead and jump into physical exam. So in terms of vitals, her temperature was 36.4 Celsius. Heart rate was 85. Respiratory rate was 18. Blood pressure was 158/72. And she was satting 97% on room air. In general, she was in no acute distress, but appeared a little bit uncomfortable due to pain. Her ENT exam, her mucous membranes were moist. She had no signs of pharyngitis or mucosal involvement. From a cardiac exam standpoint, didn't have any murmurs. She was in normal rate and rhythm. Her lung exam was normal, and her abdominal exam was normal with no palpable organomegaly. And she had intact peripheral pulses in all of her limbs, and she had a little bit of like bilateral lower extremity pitting edema. And I have a picture of the rash because I think that would be the most helpful thing for you guys at this point. Let me just try and share my screen here. Ooh. Okay, can you guys see that? Okay. Do you want me to give you the description that dermatology gave us? Or do you guys want to take a look and we can pause here and get y'all's impression?
I think for people who may be listening to the recording via audio, we can go ahead and give the description. But then, yeah, Sharmin and I can riff on what we're seeing too.
Yeah, for sure. Dermatology described the skin exam as a diffuse petechial rash, worse in the distal extremities, chest, and upper abdomen that spared the palms and soles. They noted purpura of the lateral fingers bilaterally with bulla of the third and fourth digits. There was no associated skin peeling or drainage. Her digits were warm and appeared well perfused. And there was a small petechial rash involving the nose with purpura present as well. And I will pause there. Do you guys want me to leave the picture up for this part of the discussion?
Sure, that sounds great. All right. Well, I will go ahead and get started. So I think, honestly, what I am translating this to now, based off of the appearance, and to be specific about the features, thanks for the thumbs up, Zoom. To be specific about the appearances of this that are the most notable is, this looks like bruises scattered all throughout the body. And we sort of, again, the different distributions of the rash matter, but so too does how deep the color is. And this sort of deep purple, violaceous, hemorrhagic appearance to this is making me map this on to a bleeding process. And we have that in the description as well, right? We see petechiae. The petechiae may coalesce together into the form of purpura, but it's all the same thing, right? Severe subcutaneous ecchymotic lesions that are coalescing, for example, in the fingertips. And I tend to sort of just rely on the same bleeding diathesis framework for the skin as we might do for other parts of the body. And sort of ask myself, is this a problem with the coagulation cascade? Is this a problem with platelets? Or is this a problem with the vessel wall, right? And there's sort of exemplar diagnoses in each one. Within the coagulation cascade, that could be a qualitative problem. So there may be things that are leading to dysfunction. A lot of times, for example, medications like apixaban can lead to dysfunction of elements of the coagulation cascade. Or it could be a quantitative problem where numbers are absent, whether that's related to liver disease or DIC, where things are being destroyed, or the presence of a factor inhibitor that's leading to low active levels of certain coagulation factors. So we could have qualitative or quantitative coagulation issues. We could have qualitative or quantitative platelet issues, and that could be due to things like thrombocytopenia, which is a quantitative problem, or a qualitative problem. For example, aspirin or certain medications could do it. This is far too severe to be just from aspirin use alone. So if the platelets are in play here, it would almost certainly be a quantitative problem. And then there's a variety of diseases that could impact the vessel wall, whether that's a vasculitis, which we may expect to have palpable purpura here, or underlying vasculopathies. For example, amyloid can cause dysfunction in the vessel wall. There's rare things that can do it, like certain nutrient deficiencies. But that sort of is the general framework that I'm using here. I think based off of the exam alone, all of those are at play. And really the laboratory analysis helps us make probably the most progress on that. But yeah, I'm curious, Sharmin, what else are you thinking about here?
Yeah, I really love that approach. And I have a very similar approach, thinking about the blood vessels themselves and the blood and what could be going wrong. I've always been fooled with varying presentations of endocarditis. So I think that's one thing to know, didn't note any murmurs on exam. However, that's one thing that I have in mind. And also thinking about infections and then potential complications of that, like DIC in particular, as you mentioned, that can cause a very degree of coagulation cascade. The other thing, we didn't see any anticoagulations on, as you mentioned, in her symptom, like warfarin is the one that, with skin necrosis and stuff like that, can have varying presentations as well. So I totally agree with that. I think lab work in general would help us make the most progress in this case. And again, yeah, vascularity is also a good thought. So I think the question is this an infection or complications of that? Is it an autoimmune process to begin with? So excited to hear more.
Yeah, awesome discussion. Okay, so let me take you guys through some of the initial lab work that we got. So CBC had a white blood cell count of 8.6 with a normal differential. Hemoglobin was 12.5 with an MCV of 97, and her platelets were 374. Her basic metabolic panel was normal. She did not have a globulin gap. Her total bilirubin was a little bit elevated at 1.7, and it was mostly indirect. And her AST, ALT, and ALK phos were all normal. So some of the other initial labs that we got were an LDH that was elevated at 320, a haptoglobin that was normal, and she had a normal ferritin, B12, and folate. Her CRP and ESR were both normal as well. And she had a CPK that was elevated at 332. And then we got some coag studies that showed normal PT-INR, normal PTT. Her fibrinogen was low at 185, and her D-dimer was high at 12,000. We had a peripheral smear that didn't show any schistocytes or other grossly abnormal cells. And she had a UA that was normal. And then we had some basic infectious serologies that were all negative. And those were HIV, hepatitis C, hepatitis B, and a quantiferon gold test. She also had an upper respiratory pathogen panel that was negative for COVID, influenza, and RSV.
All right. Super interesting. So kind of walking through the labs, and I'm just going to discuss as you were revealing and thinking about how, as you were revealing information, my thinking was evolving. So I think right off the bat, the two things that I was paying close attention to was platelets, because again, there's some element of petechial rashes and platelet dysfunction often cause that, and the platelets are normal. There are conditions that can cause a platelet dysfunction, but again, I don't think we are dealing with one of those things. And the hemoglobin, again, 12.5, just slightly lower. By not very anemic, because as more information was revealing itself, I was wondering, is this a case of a hemolysis? Since the indirect beliefs of the LDH is up. The haptoglobin is sorry, I thought the haptoglobin was normal. Was it low?
The haptoglobin was normal.
Okay, got it. The haptoglobin being normal, it's quite interesting. When it comes to like hemolysis, haptoglobin tends to be the most specific sign. If you're worried about that. Haptoglobin is also a acute phase reactant. So oftentimes in setting up inflammation, it could be elevated. So although it makes and the haptoglobin being normal decreases the chances of dealing with the hemolytic process, doesn't completely eliminate it. The one thing that I was like worried about from the get-go that I mentioned was DIC. With DIC, one of the biggest features of it is the coagulopathy that you see with the PT-INR and PTT that is normal. That is, in my mind, a little less likely. So I think like the other thing to think about as well is that, you know, with the CK that is like mildly elevated in the setting of all of this like a muscle involvement, just having myalgias, I'm not sure if that is noise or signal. The level is like low enough that for me, I would just, I'm not included in the problem representation of this illness that is forming in my mind. In terms of like the LDH being elevated, oftentimes we think about, is there any cells bursting, whether it's like platelets, red blood cells, white blood cells, muscles, anything that can cause elevation of that. Are we dealing with, you know, a leukemia, lymphoma that can cause elevation of that as well? I'll pause here and then let Jack reflect on the rest of the labs.
Yeah, you know, I think what I'm contending with here is as we look more at the coagulation levels is, you know, we have sort of our first pass coag levels are normal, but then we have this sort of sneaky finding of the low fibrinogen levels and then the very high D dimer levels. And I think what we have here is as kind of, as you were saying, Sharmin, maybe like a clinical feature that could be compatible with DIC, where there could be clotting in the subcutaneous vessels, and that could be leading to the presence of these purpuric lesions because of basically progressive necrosis and progressive necrosis of the skin, and then also which can also lead to associated hemorrhage. And so I'm trying to decide, like, is this a bleeding diathesis or sort of a bleeding clotting problem with normal coags, or is the low fibrinogen really signal here? That's one feature that I'm contending with. And then the other thing that I'm noting here is sort of, as you mentioned, the sort of background symptoms, the fact that she has an autoimmune diathesis in her family, and then also where these things started. It's a pretty interesting area in terms of where the rash started, which is at the fingertips and at the tips of her nose. And I have an association, I don't know if it's a correct association, but an association of like the cold diseases as tending to start there, right? Raynaud's phenomenon, we can see it on our fingertips. Cryoglobulinemia can manifest there. Cold agglutinin disease can manifest there. And then there's also another disorder called cryofibrinogenemia that can also that can also be sort of associated with these cold locations. And cryofibrinogenemia is similar to cryoglobulins in that it sort of is a sort of constellation of proteins lumping together that tend to cause problems in the cold areas of the body. The cold diseases like cryoglobulins, cold agglutinin disease, right, they can progress to become more diffuse as this process kicks off. Cryofibrinogenemia, if it's something that we test for in the same way that we test for cryoglobulins, we can test for cryofibrinogen levels as well. So it sort of is the presence of an abnormal protein that leads to abnormal precipitation of fibrinogen that then sort of sets off this whole cascade. And so I'm wondering if the combination of low fibrinogen levels and high D dimers, which is very similar to what we see in DIC, the sort of consumptive coagulopathies, I'm wondering if it's that sort of physiology and it happened to have started in areas of the body that are sort of maybe more frequently exposed to the cold. If we discover one of these things, right, one of the cold diseases like cryoglobulins, cryofibrinogen, or cold agglutinins, all of which I think would be reasonable to test for, it just opens a door into looking for other associated diseases. Certain infections can be associated with them, like hepatitis C. A variety of different autoimmune diseases can be associated, like lupus and rheumatoid arthritis, of which she has a history. Some other connective tissue diseases, like scleroderma, can also come along with this if we think about Raynaud's phenomenon. And then certain underlying malignancies, particularly immune activated activating malignancies like lymphomas can also play a role here. So I think that might be where I would first explore before going down the bleeding diathesis with normal coags, just because we have that interesting laboratory signature. But again, even if we discover one of the sort of DIC or one of these other sort of cryo clotting problems, the door opens into looking for the underlying autoimmune disease, the sort of chronic infection, or the underlying cancer.
Great, awesome discussion. So the next aliquot has some pathology in it. So dermatology did a punch biopsy of her right thigh that showed microthrombi affecting dermal vascular channels with no associated vasculitis. And they said the findings were consistent with a thrombotic vasculopathy. Do you guys want me to pause there and let you talk about that, or do you want me to reveal some more lab data?
I'm happy to riff on that briefly here, just because I think it's helpful pathophysiologically to understand. I think Sharmin may have frozen briefly. So I think the path helps us here, right? Because we had the question of, we see this abnormal skin exam, and we're like, oh, is there bleeding underneath the skin? And that bleeding underneath the skin could be due to actual bleeding, or it could be due to clotting, which leads to ischemia, which leads to extravasation of blood, which then leads to similar looking skin findings. And so I think the biopsy really helps localize us, as you were saying, Zach, into the thrombosis, the sort of microthrombosis side of the spectrum here. And that microthrombosis problem is going to be sort of, again, all of the clotting things that we think about. Is there something like DIC, APLS, the cold diseases? Is there potentially disseminated tumor within the vessels, which is a rare thing that can do it? Or are we dealing with a certain underlying vasculopathy, like you had mentioned, the sort of clotting vasculopathy, which is really this sort of same list applies. And then just because we mentioned the underlying autoimmune diathesis here, again, scleroderma can sometimes have a vasculopathy like this. Wouldn't be high on our list at this point in time, but sometimes we have to go and hunt for some of those associated symptoms like dysphagia, skin tightening, Raynaud's phenomenon, and things like that. And so I think this would sort of localize us into that clotting side of things, which includes all of the diagnoses Sharmin has already mentioned and that we've talked through a little bit. And we might go and ask her or her family members more questions to see if there's any other associated symptoms that could tip us off here. Have there been B symptoms and night sweats that might clue us into a lymphoma? Have there been other connective tissue problems that might make us worry about something like RA, lupus, or something else? So I think that that's where at least what the biopsy does for me is really situate us into the microthrombi side of things rather than the bleeding diathesis side of things.
Sorry, I got frozen, but easiest thing to say, completely agree with Jack.
Awesome. Yeah. So the next aliquot is kind of the last chunk of data and has some additional kind of like serologic testing that we did. We did go back and do like a pretty thorough like rheumatologic and malignancy related review of systems that really didn't give us any other information other than what we got in the HPI. So in terms of some autoimmune labs that we checked, she had a positive ANA at a titer of 1 to 640, but with a negative double-stranded DNA and negative ENA panel. Her C3 and C4 were both normal, and she had a slightly elevated rheumatoid factor at 31, which is like 1 above the upper limit of normal for our lab. And her CCP was normal, and she had cryoglobulins that were negative. We also got x-rays of her hands, feet, and ankles that didn't show any bony or articular abnormalities. And then in terms of like additional thrombophilia workup, she did have antiphospholipid serologies tested that were all negative. And then she had testing for like prothrombin gene mutation, factor V Leiden, and some of those other inherited thrombophilias that all came back negative. And in terms of like infiltrative disease and malignancy evaluation, she had an SPEP and a UPEP with immunofixation that were normal. Her kappa and lambda ratio was normal. She had a CT chest, abdomen, pelvis with IV contrast that didn't show any signs of malignancy. And she was up to date with all of her age-appropriate cancer screenings. And so the next aliquot has like one additional test that reveals the diagnosis.
All right. Wow, kudos to you all for just such a thoughtful and thorough workup. So kind of going through the lab, again, with the double-stranded being negative, lupus is a lot less likely. And I think the question is, as Jack already had mentioned, like we were leaning away from any bleeding disorders, and kind of it's reflected in this workup. So the question is what else this could be. I think going back to the, cold agglutinin diseases, one was that, like, I think was on the differential, and that is worth considering. And I think cryo, if I can pronounce, like a cryofibrinogen type. I have to like read again in terms of how to best diagnose that, but that's another one that was that is still on my differentials, and in my mind is often associated with other underlying diseases. The other thing with her age, that the other disease that I've often been fooled with is extranodal extraintestinal manifestation of IBD that oftentimes can present with a low fibrinogen as well. And then the last but not least, I think, is the vasculitides, like especially small vessel vasculitis. And I think with like, I don't know if she had a smoking history with like burgers with ulcerations in the hands, like that is another one to consider at this point. Jack, what are your thoughts?
Oh man, I think it's so tough. Like I can't say that I can make a ton more progress with the new data that like we sort of had this very, very large DDX, and what has come back positive is an ANA. I have a hard time, like I trust Zach and the team in terms of like the cryos were negative. And I feel like so often the cryos are negative, even if it is a cryoglobulinemic disease, because it can be so hard to run the assay not to run the assay correctly, but the assay is just very, very finicky. And so I think it's hard for me to know what to make of the negative cryoglobulins. We could test for, in the same way that we can test for the cryoglobulins, we can test for cryofibrinogenemia. But I'm just trying to think of like, well, what other underlying disorder could it be here that would give us a positive ANA, no cytopenias, normal complement levels, and a sort of diffuse thrombotic illness. APLS, again, with normal platelets, normal PTT, and a totally negative panel seems very hard to invoke. Lupus without any other manifestation seems hard to invoke. Sjogren's can sometimes come up as like a normal complement disease and can sometimes have a positive rheumatoid factor. But I'm mentioning that as really like a shot in the dark because there's no other really manifestations of Sjogren. We don't see parotitis. We don't have xerostomia or xerosis. We don't really have any of the other manifestations there. The malaise, polyarthralgias, myalgias, and fevers, it's like any inflammatory disease can do that. And so I'm not sure like really where I could go here. Like I think a delayed presentation of an autoimmune disease seems plausible, and like Sjogren's, scleroderma, mixed connective tissue diseases, some of those seem plausible. An underlying lymphoma that is yet to be discovered seems plausible. And yeah, I think and then certainly, not to be fooled by some of the infections that can do this like diffuse clotting picture. You mentioned endocarditis, disseminated gonococcal infection, and meningococcemia seems a little bit less likely because she's still alive and it's been going on for this long. But I think those would sort of be the things that I would look to next. But beyond listing those things, I don't know that I can weigh probabilities in a way that would be true to my knowledge base at this point in time.
Can't wait to learn from you, Zach.
Yeah, such a good discussion. And I'll give you guys credit because you did mention the diagnosis at some point during the discussion. So yeah, so we
If you just mention every disease in medicine, you'll probably get the diagnosis.
Yeah, thanks for trying to give us a point, Zach. We appreciate that.
Yeah, our hematology colleagues who are heavily involved in this patient's care asked us to send cryofibrinogens to the lab, and those came back positive on 2 different times that we sent them off. And so they felt like her presentation was most consistent with cryofibrinogenemia. And that kind of begged the question, like, was this a primary disorder or a secondary disorder related to something else? And when we talked with the patient a little bit more, she had a very mild version of these symptoms about a year prior, after she had like a mild coronavirus 19 infection. And so preceding this, she had some like slight viral URI-ish symptoms. And so the hematologists and the rheumatologists that were involved thought this was most likely a secondary cryofibrinogenemia related to her prior COVID-19 infection that had recrudesced with like a recent viral illness and just became a lot more fulminant for whatever reason. And so she was started on some IV heparin inpatient, and her symptoms kind of stabilized. And she followed up outpatient with one of our like med derm room colleagues who kind of specializes in diseases like this, and was started on some pentoxifylline and azathioprine and continued on a DOAC. And her symptoms improved dramatically. And now she's actually off all of those medications except for like a low dose apixaban. And if she avoids cold temperatures and takes that medication, she doesn't have return of her symptoms at all anymore.
Wow, what a case, Zach. Thank you so much for presenting. My brain is very stretched, and so we got a good exercise. Yeah, no, super interesting. And yeah, I think you all nailed it with thinking about like secondary causes of it. I think like autoimmune tends to be the most common, and like followed by like vascular disease, malignancy. It kind of sounds like, if I remember hearing you correctly, that she's had like cancer screening done. I think colorectal is like one other to kind of watch out for in these patients. But yeah, fascinating case. Like, wow, infections, they can do anything. Jack, any thoughts?
No, I think one of the things that I always struggle with in these cases is like, what do we take from a case like this? Like, I'm sort of, I'm like, am I really going to ever be able to memorize all of these factors of cryofibrinogenemia? And so in my mind right now, I'm like, what are the key takeaway points? I think the things that I'm taking away is like where it started as being a clue, like those sort of, I guess, what are they called? Like acral, or sort of like the distal surfaces. Like that's a clue for maybe a cold disorder. And then I'm honestly trying to collapse cryofibrinogenemia into the other autoimmune hematologic problems. So like if we think about like autoimmune hemolytic anemia, immune thrombocytopenia, factor inhibitors, cryofibrinogen, cryoglycogen, they're all kind of the same thing. As a process activates the immune system, leads to the development of abnormal antibodies or sort of abnormal immune processes that leads hematologic things to do bad things. That could be hemolysis, that could be platelet destruction, that could be things that inhibit the coagulation cascade, or in this case, destroy fibrinogen levels. And I think I'm like, oh yeah, it's always the same things. Sometimes it's an infection, autoimmune disease, or a cancer. Sometimes we never know, and we just call it idiopathic or primary in origin. And I think for me, that's like the general knowledge structure that I'm trying to take home and be like, which hematologic factor it is, red blood cells, platelets, coag cascade, is, there may be variations between them, but the underlying drivers seem to be at least decently similar for a generalist like me. So that just sort of is like the knowledge consolidation that I'm trying to do, is like, how can we map this on to other common disorders? Because I think whenever these come up, I feel so nervous and anxious trying to solve them, because I'm like, I just don't remember the nuances. So being like, is there a general framework that we can fall back on? And like the similarities between the immune mediated hematologic phenomenon feels like that's at least like one of the sort of like meta structures that I'm trying to take from this place, with the nuance being the cold things tend to be fingertips, toe tips, and nose tips.
Beautifully said. Zach, any other reflections from you?
No, I don't think I have anything else to add. I saw this patient when I was like during the first month of residency, like 3 years ago, and
Wow.
had never like seen a patient with a purpuric rash. So like my like main take home was like learning how to approach purpuric rashes and have a good differential for that. And then I'd never heard of cryofibrogenemia, so didn't even know that was a possibility as a diagnosis. And so that was kind of like my take home is that that's on the differential for these kind of thrombotic vasculopathies.
Mhm. I really love that. I mean, I think what you're referencing and what Jack is thinking about, like, again, like how we're framing these patients, and we can't remember everything in medicine. There are who can. I'm definitely not one of them, but thinking about how you're framing them and what are those salient features that help you make progress. And in this case, having a purpuric rash with the thrombotic picture, and then as Jack mentioned, like where it is starting, I think is like a good clue to set us in the right path. And thankfully, in real life, we have a lot of help from experts too. This is awesome. I learned so much from everybody. That to you for teaching points.
Amazing. Thank you so much, Zach, for another great case, great discussion, Sharmi and Jack. I will go for my favorite teaching points. When we see this patient presented with bruise, deep eviolysis, petechiae, and severe ecchymotic lesions, we learned that we can think about the problem could be in the platelets, in the vessel wall, or the coagulation cascade. And in the platelets, we can think it could be quantitative, it could be like a thrombocytopenia, or qualitative, it could be an aspirin. The vessel wall, we can think about vasculitis, a vasculopathy, endocarditis. And the coagulation cascade, we think about the quantitative liver disease, DIC, or factor inhibitor, and qualitative dysfunction could be like a medication again. And in this patient, we have like the aptoglobin that is really significant for hemolysis that is normally elevated, and in this case was kind of normal, so can decrease the chance of a hemolytic process. And we had like the rash started on the fingertips and nose, and we think about renal, acryoglobulinemia, and a fibrinogenemia. I never heard, it was my first time. That this is similar to cryoglobulis, but there is like a protein that can precipitate low fibrogen and can be associated with hepatitis C, lupus, rheumatoid arthritis, scleroderma, and lymphoma. And in this case was a cryofibrogenemia that was secondary like to COVID. Thank you so much.
Boom. Amazing job, Deb, as always. I like how incredibly succinct, thoughtful those teaching points are and how fast you all do it. It never ceases to amaze me. Thank you, everybody, for joining us. Sorry for the technical difficulties. See you next time. Bye.